Okay, great. I think we're live and we can get started. Hello, good evening. Welcome to tonight's installment of Ask an Expert. My name is Amanda Wroblewski. I coordinate the PILLAR Program with Boulder Community Health. My pronouns are she, her, hers, and we are thrilled to have you with us this evening. Thank you for coming, either during the live stream tonight or if you're watching the recording. As I mentioned, I coordinate what's called the PILLAR program. PILLAR is a program embedded within the BCH healthcare system that helps navigate treatment to substance use disorders or management of chronic pain without the use of narcotics. We also provide short-term case management and some limited scholarship dollars to cover gaps that may exist in care. We're here tonight for Ask an Expert. This is our monthly educational lecture series that is so generously supported by the City of Boulder. And this is an opportunity for us to come together, create safe spaces, talk about anything and everything related to substance use, mental health, trauma, chronic pain, some of these really big issues that we're trying to tackle kind of one little step at a time. So I always like to kind of set up the expectations for the evening. We will have a speaker tonight. We are so excited to welcome back Ms. Madeleine Evanoff from Boulder County Public Health to talk to us about how to save a life using naloxone and what can be expected around, before and after an opioid overdose. So we'll have a few minutes at the end to answer questions and talk a little more about this subject, but please, throughout the discussion, feel free to put questions or thoughts into the chat box. It should be on the right of your screen. I, as always, will be the disembodied voice facilitating any questions or discussion points. We'll try to get to everything. Hopefully we'll be able to. And Madeleine will give her presentation, like I said, and at the end we'll have time for for more questions. But I always like to mention that this is not a one-off answer to those big issues I mentioned in the beginning of my spiel here. This subject in particular, because it does focus on harm reduction and reversing opioid overdose, can make people react very strongly. We want to keep discussion appropriate, but we do want to talk. We want to create, again, safe spaces to have these discussions because that's how we fight stigma and end overdose. So with that, I will turn it over to Madeleine. Sit tight for 1 second. We're going to trade spots and she will be right with you. Thank you.
So much, Amanda. I'm very excited to be back as well. So once again, my name is Madeleine Evanoff. My pronouns are she, her, hers, and I am a harm reduction specialist with Boulder County Public Health with our Works Syringe Service and Harm Reduction Program. And as Amanda introduced this presentation, really this is going to be an opportunity for us to do a little bit of an overview on several things. So first, just harm reduction in general. For those of you who were with us for the last presentation, it'll be a bit of review, but I just want to make sure that we all are on the same page as we enter into content more specific to opioid overdose reversal. I am always wanting to get information about our program out to people. It's so important to refer folks our way. If you have any friends or family or you yourself could benefit from our services, that part of the presentation, hopefully you'll be able to get some some information that is helpful with that. And then, of course, we'll move into that Narcan training. So that's going to be the meat of our time together this evening. And really with that Narcan training, what I've found is so often we really focus on the before and the after, because the administration of naloxone itself is an incredibly simple thing, which is so wonderful. It's such a gift that it's so easy. So we will have time to walk through what to look for, what are the risks, and then what to expect afterwards. And of course, time for those questions as well. So just to kind of bring us all together into the same space, human beings in general, we engage in behaviors every single day that carry some risk with them, right? All of us, whether it's riding your bike, whether it's driving in your car, whether it's legal substance use like smoking cigarettes or drinking alcohol, smoking marijuana, sex, right? All of these carry some risk associated with them. And we all also, almost every day, engage in some type of harm reduction. So these are practices that we utilize to help reduce the risk associated with these behaviors. So more recently, we're probably really familiar with things like masks and vaccinations, wearing seatbelts, wearing helmets, maybe drinking green tea instead of coffee, although I am not in that boat myself. So this is really just a way to normalize the fact that all of us want to live the healthiest life possible. And that certainly is true for folks who are using drugs as well. So when we look more at harm reduction, specifically as it relates to people who use drugs, the first thing that I feel is really important to do is to acknowledge that this is a movement that was created by people who use drugs for people who use drugs. So people who use drugs have experienced so much stigma throughout the years that when it has come to their own health and well-being, they really have had to take that initiative in keeping their loved ones as safe as possible while using substances. So it's great that public health is here, that we're on board with syringe service programs, with opioid overdose prevention, but these really are things that were started by people who use drugs. And also, just knowing that there's this huge spectrum of harm reduction, right? And so we can look at these really big, broad, more macro type approaches to harm reduction, such as policy. So like in the state of Colorado, syringe service is legal. That's great harm reduction. But really when we filter it down, harm reduction is that one-on-one experience that we have with people who are using drugs, where we are able to show compassion and radical acceptance and empathy and respect and reflect back dignity, right? That's what harm reduction boils down to.
Can you give an example of radical acceptance?
Absolutely.
To put you on the spot.
No, that is totally fine. So when we talk about radical acceptance, what we're talking about is really being aware of our own biases, right? And our own agendas. Looking at, somebody walking through the door and talking about daily substance use that we can see is impacting their relationships, their ability to hold a job, their ability to have housing, and not putting our terms and conditions or agendas on those people, right? Being in that space where we're able to hear what their needs are and they are able to dictate their path forward.
Fantastic definition. Thank you.
Awesome. Okay, so a little bit about our program. I always like to brag here because we are the third syringe service program that started in operation in the United States, and I cannot take any credit for that. That was back in 1989. I was 1 year old, so no credit for that. But the really wonderful, there's lots of wonderful things about that, but one really, really wonderful thing is that we've been able to build such fantastic relationships within our community. and such a support network in our community for people who use drugs. And that goes from law enforcement and the DA's office and the Boulder County Sheriff's Office to programs like Amanda's, the PILLAR Program, Denver Recovery Group, Behavioral Health Group, places like Recovery Cafe Longmont. We have all of these partners, Boulder County AIDS Project, mental health partners, all of these programs that help support our people, and great resources for them to help really connect them to that whole body health that we want for people in our community, right? So what we do, we are an anonymous program. So people walk through our doors. We do not ask for a name, date of birth, anything like that. We assign people a little anonymous code. That code is put onto a participant card and is used every time they access service. So that's how we track how much of a product we're handing out and connect it to an individual without identifying information. That card also serves as legal protection for our participants. So if someone is carrying that card and they have drug paraphernalia on them, they are exempt from paraphernalia charges, even if those supplies have been used. So it doesn't protect against anything else, nothing like possession, but it does protect against paraphernalia.
What would be included in paraphernalia?
So that would be any of the product that we hand out. That's going to be safer drug injection, smoking, and snorting equipment. So some examples of that would be syringes, cookers for cooking certain drugs, fentanyl test strips, glass pipes, which we hand out for smoking both methamphetamine and crack cocaine, and a myriad of other supplies that we provide. But those are just some examples of what would be covered. We do a lot of education on health, like vein care, wound care, and of course, overdose prevention is a huge piece of that. So we provide naloxone, fentanyl test strips, and of course, train people on how to use them. And we do offer rapid, free, confidential HIV and hepatitis C testing to people. And we have a great case manager who's able to help walk folks through resources that they might need a little bit more assistance. So now that we have finished up those pieces, we are going to jump into why you all have joined us tonight, which is having a conversation about Narcan. And what I want to start by saying is, so naloxone, you'll hear me interchangeably using naloxone and Narcan, but I want to be able to define the difference. Naloxone is the actual medication that reverses an opioid overdose. Narcan is a brand name of naloxone that is 4 milligrams in strength and administered intranasally. So the training that I'm doing tonight is specific to that Narcan, but naloxone does come in some other forms. There is an intranasal naloxone that is 8 milligrams in strength, and there also is still an intramuscular injection that can be provided. Okay. What are opioids? So I am going to simplify this. I'm going to boil it right down, and really just to get a picture of what opioids are, right? So all of us have naturally occurring opioid receptors in the brain. These opioid receptors are part of what the brain uses to process our feel-good chemicals, our neurotransmitters. And so opioids are any number of drugs that can enter the body and utilize those same naturally occurring opioid receptors. Opioids can be opiates and opioids. So opioid is kind of that umbrella term. An opiate is more something that's natural. So think of something that's derived from the poppy flower, like opium or heroin, right? Opioids tends to be, it's the umbrella term, but it also tends to signify something that's a bit more lab created, a bit more synthetic. So think more like those pain medications that we all might be more familiar with, like fentanyl, oxycodone, codeine, methadone, right? And many opioids are a combination of synthetic and natural. And that really doesn't matter a whole lot. What matters is just knowing that naloxone only reverses an overdose that is caused by an opioid, right? And you don't have to know what the opioid is or how to pronounce it. Naloxone's going to work if it's an opioid. It's a really safe medication. It's been around for a very long time. So actually, it was created in the 1960s. So it has a long history. And one great thing about that is that we've been able to study it in lots of different populations of people, right? Youth, people who are pregnant, people with certain underlying health conditions. And what we have found is that across the board, naloxone is a very safe medication. I really want to drill this point in because one of the biggest fears is, what if I don't know it's an opioid overdose and I give somebody naloxone? Oftentimes we don't know for sure, right? They could have mixed substances. It could be a totally different substance. It could be an entirely different health event, right? All you need to know is that if it's an opioid overdose, naloxone's going to work. And if it's not, naloxone is not going to hurt that person. All right? So what is an opioid overdose? When opioids enter the brain and attach to those opioid receptors, opioids are a depressant. So they're going to slow down the central nervous system. They're going to create a sense of relaxation. People are going to slow down, right? Their breathing's going to slow down. Their heart rate's going to slow down. And oftentimes people will start doing what we call nodding out. And that is quite literally someone's eyes are, maybe fluttering. Their head might be kind of plopping forward every now and then. And it's very normal for people who are high to experience this. The big thing is that if you wanted to rouse that person, you would be able to get a response from them still, right? So when somebody overdoses on an opioid, what happens is it slows down the central nervous functions too much. So all of a sudden that person's breathing has slowed down so much, has become irregular enough, or has entirely stopped, and they are no longer getting the oxygen that they're needing. There are several things that we know can really increase the risk of an overdose. One is going to be decreased tolerance, and that's a really, really big one. We see that often with our folks who are coming out of jail or prison, maybe have spent some time not using and all of a sudden begin using again. Someone's tolerance is going to be a lot lower. It's pretty easy to overdose. Anytime somebody mixes opioids with another substance. So this is not 1 + 1 = 2, but 1 + 1 = 4, right? And so we have, especially when an opioid's mixed with another depressant, like a benzodiazepine or alcohol, it can really increase that impact of slowing down the central nervous system. We are working within the confines of an illicit drug market. People really don't know what they're getting. That's really going to increase the risk of overdose. So as much as we try to provide fentanyl test strips, the reality is fentanyl's primarily what people are using, and most people know they're using fentanyl. So fentanyl test strips are no longer really as effective as they had been previously.
Sounds like people are currently seeking out fentanyl as their primary drug of use.
Absolutely.
Okay.
Absolutely. And for those folks who are still wanting heroin, it's actually becoming pretty hard to find it. So with that being said, people might have a better sense of, I want fentanyl, I know that's what I'm going to get, but the strength is still very inconsistent. And we also know that there are new opioids being manufactured and put into illicit drugs all of the time, right? The biggest risk for dying from an overdose is going to be using alone. And that's something that we really, really try to stress to the people that access our service. Can you use with other people? If you can you take turns using so that you don't all use at once and potentially experience an overdose all at once? If you can't use with another person, can you call somebody and keep them on the phone with you while you're using? So that's one that we really, really want to try to work with people on, because it's fentanyl. You have to act very, very quickly when somebody overdoses on fentanyl. The time that it takes from someone to go from respiratory depression to cardiac arrest is pretty quick with fentanyl, as opposed to something like heroin.
Do you have a general idea of what that time frame might look like, or is it variable?
It is definitely variable,
Sure.
but it's more in line with 5 to 10 minutes for fentanyl, which is super fast.
Yeah.
Versus 30 to 60 minutes with heroin.
Wow.
So very, very fast. Yep. Yeah. And then, of course, a lack of access to harm reduction programming can really impact people negatively. So we talked a little bit about harm reduction when it comes to using alone. And quality and consistency of drug, right? We have fentanyl test strips. That's unfortunately really the best we can do at this point. Other than people using their drugs slowly, try not to mix. If people are mixing, trying to use the opioid first so that they kind of get a sense of how that drug is going to hit them prior to putting another substance on board. And some of these might feel really controversial to folks that aren't used to talking about harm reduction and substance use. But I just want to reiterate that our goal here is to keep people alive, right? Mm-hmm. Because if somebody dies, they can't ever enter into recovery.
Right.
So signs of an opioid overdose are going to be signs that somebody is not getting enough oxygen anymore. The biggest ones are going to be you are not able to wake somebody up or get any type of response from them. You're yelling at them. You're doing what we call a chest noogie, which is rubbing your fist up and down on somebody's sternum. They're not responding. So that's a big one. The next one is going to be any type of change to breathing. So it could be slow or stopped or irregular breathing, but also what's very common with an opioid overdose is like a choking, rasping, gurgling type noise when somebody is trying to pull in a breath of air and they're not able to do it. Any type of change from somebody's typical skin tone. And then less common, but possible, would be somebody who appears awake but is unable to speak. Typically, folks' eyes are going to be closed, so you're not going to be able to assess the pinpoint pupils, but that is a sign of an overdose. Okay, so responding to an overdose, I'm going to move through this slide, and then I'm going to actually show you what the box looks like and what a kit of Narcan looks like for you all. So first, what we're going to do is we're going to check for responsiveness, and there's two parts to this. So the first is going to be what we call a verbal Narcan. We're going to try to get somebody to wake up, right? So you're yelling their name, and then you say something to the effect of, if you don't wake up, I'm going to give you Narcan. Most people who use opioids know what Narcan is, and if they don't need it, they don't want it, and they will let you know that, right? And if they let you know that, if they say they don't need it, please believe them. If they're able to say no, they are not overdosing. So it's going to be that verbal Narcan, and then you're going to move into some type of pain stimulus. So the most common is to make a fist, and then you rub it as hard as you can up and down that chest plate. And if you put enough pressure, it's pretty dang uncomfortable. Mm-hmm. So somebody should respond. You will then administer Narcan, which I will show you what that looks like in just one moment. After you administer Narcan, you will call 911. If there's more than one person there, clearly one person can take 911, one person can administer Narcan. But pretending that there's only one person there to respond, you would want to try to get one dose of Narcan in before calling 911. And then rescue breathing. So if somebody has completely stopped breathing or their breathing is really irregular, that's when you move into rescue breathing. This is a really, really imperative part of reversing an overdose. The one thing they're not getting is oxygen. That's what they need. So we unfortunately do not provide face shields through the Works program. You can purchase them on any type of online store like Amazon. You can go in and purchase them. Most CPR classes hand them out to folks. But the rescue breathing is really, really crucial. That's going to be plugging someone's nose, doing one normal size breath in for them, and repeating that every 5 seconds, right? So you have somebody lying on their back, preferably, right? They're lying on their back. Their chin is tilted just a little bit so their airway is open. And every 5 seconds, you're pinching their nose and giving them that rescue breath. So with the Narcan, I don't know if there's any way to hopefully get the camera on the Narcan, but no, that's okay. I don't know if you have to zoom in. So the Narcan, Narcan comes in a box like this. And inside of that box, there are going to be 2 doses, and each dose comes in its own little blister pack. All right. So 1 dose of Narcan looks like this. And really, Amanda and I were actually just at a conference, and this amazing doctor was talking. I'm going to steal it from him. And he was like, if you can locate the nose on somebody's face and make this motion with your hand, you can administer naloxone.
You've been trained in Narcan.
You've been trained in Narcan.
Shout out to Dr. Bob Valek with the Colorado Consortium.
Thank you. Yeah, that's it. That really is how easy it is, right? So you take this white tip, you put it as far up somebody's nose as you can get it. And that's really important because you want it to enter into the sinus cavity, right? And then you push the little button, and you'll feel and hear a little click when you push that button. The naloxone has been administered, right? That's as easy as it is. So you administer that first dose, you call 911, you're giving rescue breaths. As soon as somebody starts showing signs that they are coming out of an overdose, that's when we try to get somebody into a recovery position, which would be on their side. People can get pretty sick, especially if they're used to having an opioid in their body. What naloxone does is it goes in, it pulls the opioid off those receptors in the brain, and somebody goes right into withdrawal. So we try to get somebody into a recovery position as soon as they start showing signs that they're coming out. If after 2 to 3 minutes, you're not seeing a sign that somebody is coming out of that overdose, that's when you would give that second dose of naloxone. It really depends on the person and the substance they've used and their tolerance, what type of an opioid it is, as to how many doses it may take to reverse an overdose. Most people will respond to the amount of naloxone that is in 1 to 2 doses of the Narcan spray. So if EMS arrive, really at that point, your responsibility is done, right? EMS takes over monitoring that person and making sure that they are given the option to go to the hospital and be watched and cared for. Sometimes people refuse that, and that's their right as well, but your responsibility at that time, as soon as EMS arrives, is over. We do like to note that naloxone is only effective for about 30 to 90 minutes. So if somebody's taken a longer acting opioid, it can wear off and they can go back into an overdose. But EMS is aware of that and they do monitor folks.
So, I mean, certainly then you would probably encourage somebody to seek medical care after an overdose event.
Absolutely.
Yeah, to keep an eye, especially past that 90-minute mark.
Absolutely.
That overdose doesn't re-engage, basically.
Yes. And if it's somebody you have a relationship with and you're able to kind of try to push them in that direction as much as possible, we certainly really advocate for that. Mm-hmm. And certainly EMS will really try to push them in that direction as well.
Sure.
There are a lot of myths about fentanyl and about fentanyl analogs, such as carfentanil. So it's, just mentioning briefly the ways in which somebody can encounter a really powerful opioid and actually experience an overdose themselves. So the only way that you can come into contact with enough of an opioid, even a really powerful one like fentanyl and carfentanil, to actually cause an overdose is if you yourself inject, smoke, snort, or ingest that substance. All right? So really what we're trying to say here is, let's say you walk into a space where somebody's been smoking fentanyl and you're coming into contact with secondhand smoke. You are not going to be at risk of overdosing. Let's say you're starting to do rescue breathing on someone and you notice that this is very, very hypothetical, but there's like a little bit of white powder near their nose or something. Having some type of skin contact with a substance is not going to cause an overdose. So just know there have been a multitude of studies done really looking at how powerful opioids can enter the body and cause an overdose, and secondhand exposure is not a way in which that can happen. So just briefly, some really dry local state laws, but just so you all are aware, you are protected under the Good Samaritan law by administering naloxone. So if you do not know what somebody's taken, if you don't know what type of health event it is, but it might be an opioid overdose, please utilize your naloxone, right? It's not going to hurt somebody. You are able to walk into any pharmacy and acquire naloxone without a prescription here in Colorado. That is a right that you have. Unfortunately, we are still kind of working with pharmacies to get them all on board with that. But that is something that we hope you are able to achieve. If you have any issues with it, please contact the Works program. We will try to reach out to pharmacies and do education.
Yeah, absolutely. And I mean, you're willing to offer that education to any pharmacy that's willing to listen.
Absolutely.
Is that right?
Absolutely.
Yeah. And definitely too, if you're outside of Boulder County, please try to contact your local health department and see what kind of resources they may have or be able to offer.
Yes. Thank you for that.
Yeah, thank you.
Syringe service in the state of Colorado is legal. Yay. And we talked about the paraphernalia protections that our participants have. And then the really, really, really big one is that the person who experiences a drug or alcohol overdose and the person who calls EMS on their behalf, those two people are going to be exempt from criminal charges. So important for people to know that, especially for people under the age of 18. If you're under the age of, legal alcohol use, if you're under the age and you have a friend who has used an opioid or may have an overdose, this law still applies to you, right? So this applies to the young people in our community as well as everybody else. This is a law that is there to help keep people, to help encourage people to call, right?
And keep people alive.
Yes, absolutely. Absolutely. So before I hop into accessing naloxone, the one slide that I kind of missed out on was what happens when somebody starts waking up, right? And once again, there are a lot of myths out there. There's a lot of fear around what to expect when somebody starts coming out of an overdose. And many of us have heard stories about somebody waking up swinging, being really pissed off. That is not what's going on for folks. What is happening is oftentimes people are incredibly ill, right? They have just been pushed right into withdrawal. So they're very, very sick. They're incredibly disoriented, right? A lot of times they don't remember things right prior to the overdose. They may not know where they are. They may not know who you are. So disoriented and sick. Mm-hmm. The best thing that you can do is to take a couple steps back and give that person their physical space and to just really gently start talking to them and repeat something very simple to them until they are fully with you again, right? So something like, "Hi, my name is Madeleine. I'm so sorry that you're not feeling well. I had to give you some naloxone. I'm here with you. We've got EMS on the way just to check in. You're going to be okay." Right? Just something really simple and calm like that over and over again, while giving folks their space. People are not going to wake up combative. They're going to wake up sick. And scared. Very, very scared. So accessing naloxone for the general community, I really wish that I had an easy answer for people, and I don't.
I know.
But I do have some suggestions. So one is, if you are using substances, even if it's irregular, like let's say you go to a music festival a couple times a year and you like to imbibe on those occasions, come see us. We can give you free naloxone through the Works program. If you have a friend or a family member that is actively using substances, you can access naloxone through the Works program for free. If you're just a general community member who wants to do the right thing, I want to support you as much as possible. And unfortunately, we're not able to provide you naloxone, but there are some options. So Medicaid and Medicare do cover the full cost. Private insurance will cover the cost of naloxone with a copay, which is still usually pretty dang expensive. Yeah. So we have actually found that GoodRx offers some very helpful coupons. There were a couple coupons I found recently for pharmacies. They were Walgreens in Longmont that were offering naloxone for $49. Still very expensive and cost prohibitive for a lot of people, but much cheaper than the $125 to $140 that a lot of people are having to pay out of pocket for it. So, accessing through your local pharmacy, accessing through the Works if you're directly tied to substance use in some way. If cost is a barrier to you and you are not yourself using substances or know anybody, but you want to have a kid on you, please reach out to us. We're happy to work with you. We want everybody to have access to this. And then on that note, we do have our locations up. So we have 2 locations in Boulder that are operated through our 2 community partners. One is the Boulder County AIDS Project and one is Mental Health Partners. And then we have one office that is in Longmont, and that is off of Kaufman Street there. So you can find all of this information on our website, which is bouldercountyworks.gov. Wonderful. And I will just keep my contact info up there as well so that folks can jot down my email or my phone number if they'd like to. But otherwise, I just want to thank everybody. This is it's a really, really important thing for all of us to learn about and know how to respond to. And it's also, a secondary impact of it is it's such a fantastic way to start breaking down that stigma around substance use, right? It gives us an opportunity to talk about it, take some actionable steps, and be allies for the people in our community that we love and care about that are using drugs.
Fantastic. And I couldn't agree more. Thank you so much. That was such valuable information presented in such a way that I feel was very, very digestible and very easy to understand. So thank you for sharing all that with us. Couple thoughts. We've definitely got time for questions and discussion. I'm curious, what if my Narcan is past its expiration date?
That is a really good question. So Narcan is good well past its expiration date. We know that. And we're saying up to 2 years past the expiration date.
Wow.
So if you're still comfortable having that expired kit in your belongings, it is still good. If for any reason you're not comfortable with it anymore, do reach out to us because we are able to utilize those expired kits for our programming.
Oh, fantastic. And yeah, if anyone else wants to chime in, just throw some questions or comments in the chat box. I'm curious. So when you talked about the myths of fentanyl, namely, the impression that people might be under how easy it is to accidentally overdose.
Yes.
Have you seen these There's some very silly videos, in my opinion, from different law enforcement entities.
Yeah.
None that I've seen in Colorado, thank
Yes.
goodness, but where officers are barely in contact with fentanyl and are experiencing signs of an overdose. It sounds like you're familiar with what I'm talking about. Can you talk a little bit about that? Because I think that is it can wildly distort people's impression
of course.
how fentanyl affects people secondhand.
No, absolutely. Absolutely. And I think that a lot of the myths that I have personally encountered are related to those exact law enforcement videos. And so what I do want to preface it with is like, I have such an immense amount of respect for folks who are going out and trying to keep our community safe.
Oh, absolutely.
Potentially
Yes.
coming into contact with things that are
Scary.
that are really scary,
Yeah.
right? But
Deadly, potentially.
but what we do know is that the mind is incredibly powerful.
Correct. Yep.
And that when we encounter a situation that we're really unsure of, there's a lot of fear and anxiety, we can start feeling things throughout our body that are not in fact happening. Right. And what has been noted based on these videos is that it's very likely that folks were experiencing some type of really, really significant anxiety response.
Mm-hmm. Yeah, more consistent with like a panic attack,
Yes.
potentially.
Yes.
I bring that up just because I feel like they've been making their way around the internet for some time
Social
now.
media
Yes.
and oh yes, absolutely.
So,
yep.
The likelihood that someone has been exposed, like consumed that piece of media
Yes.
is pretty high. So yeah, I wanted to dispel that one.
No, thank
specifically.
you.
Yeah, of course.
And one note, I don't know if any questions have come in or how we're doing on time, but I did not mention storage.
Oh,
and
yeah,
just
we've
kind of
got plenty
temperature
time.
range.
We do have another question, but let's talk about
Great.
storage.
So just really quickly, the best way to store naloxone is going to be at room temperature. And the storage specifics are on the box. They are outlined on the box. Since it is a liquid medication, the biggest thing we want to be careful about is freezing, right? So if it freezes, it's not going to come out. It's not going to be really useful to you. It can actually withstand pretty high heat temperatures, and it can withstand freezing and then thawing again and still maintain its integrity as a medication. So this is something that we do hand out to a lot of folks who are experiencing homelessness, who are unhoused in our community. So clearly just being on their person, it's going through a lot of temperature shifts, and we have never had anybody say it has not worked for them. Mm-hmm. So with that being said, would be best if you don't store it in your vehicle, but it is a pretty sturdy medication.
Great. That's good to know.
Yeah.
Then one less thing to
Yes,
worry
right?
about, that if I try to use it, oh no, it was in my car, it's going to be ineffective.
Yes.
Just kind of on a quick note, how many, just off the top of your head, and if you don't know,
gosh,
can
yeah.
you ballpark
Yeah.
the numbers for us? How many kits have you all distributed maybe this year, and how many reports of reversals have you had at the Works program?
Oh my gosh, that is such a good question.
And I know I totally put you on the spot. If you,
no,
like I said, if you have ballpark figures,
really-
if not, totally fine too.
Nope, I really should have looked into that prior to coming here. I should have been
No
prepared
worries.
for
It
that
just kind of
question.
occurred to me too.
So what I would say is that in general, on average, we have, and clearly this is very underreported, but the people who come in to access our Works program, I would say typically we have about 8 to 10 people each month who are reporting to us that they themselves reversed an overdose.
Wow.
And we know that number's much larger, right? Not
Right.
everybody's telling us.
Right.
And I would say typically in a month we have about 30 people who are newly trained in
wow.
naloxone who are part of our program. And for distribution, it's usually over 200. So just over 200 kits being given out per month. Ballpark.
Wow.
And that's just to our participants. We do hand out kits as well to community partners who engage with folks who are using drugs. Yep.
That's fantastic. That's a lot of the medication out there in the community where it's needed. While we're on that note, Narcan is also accessible in the BCH emergency department for people who are at high risk.
Wonderful.
So we make sure everyone who is at high risk or who is seen for an overdose event walks out of the door with that little pink and white box that Madeleine showed us earlier in their hands. We've got a really good question, kind of speaks to if there's a tolerance. So if someone gets dosed with Narcan on one overdose occasion, will it be less effective for a second one a week or so later if they overdose again within a smaller time frame?
That is a really great question. I've actually never gotten that question before.
Oh, really?
No, I haven't.
Wow, good question.
I know, right? So the answer to that is no. There's no tolerance that's going to be built up with naloxone, which is great. So really what it goes in there and does is it just knocks the opioids off the receptors. It's not shifting any type of chemical balance in the brain or doing anything that would create a tolerance over time. So somebody, it would be just as effective if used in a tight span. But that's a really, really good question.
Yeah, great to know. And then, certainly too, if people are needing more Narcan in a small period of time, please go see the Works program.
Yes.
So we've still got a few more minutes. If anyone else has any additional, thoughts, questions, we've got Madeleine's contact info up there. Please go see the Works at any one of their locations, or the Boulder County AIDS Project, Mental Health Partners. Yeah.
And one other myth that I will, since we have time, that I just want to make sure and bust for folks is that there is naloxone resistant opioid out there. So we've heard reports that
we've heard this too in our program,
that there are certain opioids out there that are resistant to naloxone. Certain opioids that are more powerful may potentially take more naloxone, but there is no such thing as an opioid that will not respond to naloxone.
That actually brings up a good question. You mentioned that there's another medication out there by the brand name Cloxato, right? I don't know if you said that, but
I referenced,
you referenced, the 8 milligram dose. Is that, do you think, in response to seeing stronger opioids on the street? Is one more effective than the other, regardless of the dosage? Is one preferred? Are you hearing anything from participants? I don't know if Cloxato is out there in the community quite as much as Narcan is. I don't think it is quite yet.
No, it's not yet.
But I guess what I'm wondering is just if you're getting any feedback in real time from folks that have used it or are familiar with it.
No, that's a really good question. So Cloxato is also administered intranasally. So really the only difference is that it's 8 milligrams in strength instead of 4 milligrams. So it's twice the dose in one. And people's opinions on it really vary. What I will say from the harm reduction community is that we are not a fan of it. And the reason for that being that it will, in most cases, really immediately push somebody into a very traumatic withdrawal process. And there is already so much trauma that people who use drugs have experienced when it comes to the medical field, dealing with hospital systems and emergency medical services. We don't want to add to that. So we would much rather that people dose in smaller amounts and provide that opportunity for somebody to maybe not become quite as ill. The other disadvantage to somebody coming out, people are going to feel really lousy regardless of whether it's a 4 milligram or 8 milligram, but people can really instantly want to use again, right? So if they come out and they're in severe withdrawal, the first thing that they may want to try to do is go use again because it's the only thing that they know is going to take the pain away. And the pain is very real and it's very severe. So for so many reasons, the harm reduction community is really against it. There have been some people that have really enjoyed offering that as part of their services, and they really like what Kloxxado offers, which is just that stronger dose. So I think it really is dependent.
In a professional sense, I've heard mixed reviews, right? Mixed opinions. So
Absolutely.
I was curious if you had any feedback from the community. So that's helpful. Thank you. Well, we haven't had any more questions come in. I think because you did such a fantastic job of
Thank you.
providing the information. Like I said, very, very manageable, very easy to absorb and understand, I think. So, we can certainly wrap up. Again, we want to thank Madeleine Evanoff, Boulder County Public Works. Them too. Boulder County Public Health Works Program. And shout out to our supporters, the Health Equity Fund, the C Fund, beautiful Stone Cottage Studios, where we're broadcasting from again tonight, and BCH for supporting the PILLAR program and helping people get the treatments that they're looking for. So don't hesitate to reach out to Madeleine for questions and support around harm reduction. Again, my name's Amanda. I know my contact info isn't on. We generally have a resource slide with my contact info. Wanted to keep it to the public health slide since this is more of a formal training. But you can Google or just go to bch.org/PILLAR, bch.org/pillar. You can find my contact info there and more about our program and how to get connected. So thank you. Oh, and please fill out our survey. We're grant funded. It helps us measure our impact. The link, it's a Google form. The link is right under this window. Whether you're watching the live stream or the recording of this broadcast, you might have to hit the more button or the more, link under on the YouTube page, but it will take you 3 minutes, and we would love to hear from you about this lecture, about any other lectures you've viewed of ours, and please send me feedback. What do you want to know? Let's talk about substance use and trauma and harm reduction. Let's talk about all the things.
Good.
Yeah. So, all right. With that, everybody, have a fantastic evening. Thank you all so much again for joining us, and we will see you next time.